switch to cardiology. Um, Iron poisoning is the number one cause of poisoning deaths in children under a year of age. It is a disaster. The most common source of iron poisoning is basically iron tablets, and probably for two reasons. First, anybody here taking iron? What do the pills look like? They're large and they're shiny. And what color are they? Black. Usually they're red or green. Okay, and they look like M&Ms, and they look like candy. And then iron is not a drug. Okay, so it does not have to come in iron-resistant canisters, and you can buy them over the counter in 100, 200 bottles, and the kids can get at them, and that's why they're a problem. Now, when we talk about iron poisoning and we talk about the lethal dose, the lethal dose of iron is 60 milligrams per kilo of elemental iron. So then you really have to know what the elemental iron content is of the iron tablets that the patient was taking, because ferrous sulfate has 20% elemental iron, so a 300 milligram tablet of ferrous sulfate has basically 60 milligrams of elemental iron. But ferrous fumarate is higher, it has 35%, and ferrous gluconate only has 12%. So when you're calculating the lethal dose of iron, you sort of have to know which tablets the kid got at. The number one problem of iron, okay, is it's irritating to the gastric mucosa. That's why they're enteric coated, so they dissolve in the small bowel rather than in the stomach itself. But of course, kids don't swallow the tablets whole; they chew them up like they do candy. So now the enteric coating is gone when it gets into the stomach, okay, and it causes significant GI irritation. It accumulates in mitochondrial tissue, producing cellular damage. It can cause venodilation and increase capillary permeability, which results in hypotension and basically drowsiness, coma, and in severe cases, hepatic necrosis. The hallmark of iron poisoning, okay, is nausea, vomiting, diarrhea, and severe abdominal pain because it's irritating to the GI tract. It can develop anywhere from 30 minutes to 6 hours after ingestion, and the vomiting and diarrhea may be bloody, which is another hint that it may be iron intoxication. And that's the first stage, basically. First stage is vomiting, diarrhea, nausea, and the diarrhea, vomiting may be bloody. Stage two, 6 hours later, everything quiets down. Why? Because it's now left the stomach, so the irritation in the stomach is gone. And in the next 6 to 12 hours, okay, is where the cellular damage may be occurring, okay? And patients with severe levels of iron ingestion may develop hypotension or drowsiness. Stage three, now the patient shows the effect of cellular damage, so they develop acidosis, circulatory shock, coma, convulsions, and death. This is when they die. If they make it through stage three, get to stage four, okay, and they don't die in stage three, then hepatotoxicity can occur. If they get past the hepatotoxicity, because of all the GI irritation, they may develop gastric scarring or pyloric stenosis, and this may show up 2 to 4 weeks after their ingestion. So this is a real problem with these kids. Now, obviously, if there's a history, it's easy to make the diagnosis, okay? If you know they ingested less than 40 milligrams per kilo of elemental iron, basically you really don't have to treat them. But iron is a heavy metal, just like lead is. So if you're concerned, take a flat plate of the abdomen, because if you take a flat plate of the abdomen, you may see heavy metals within the GI, within the stomach. If there's no evidence of it, then toxicity is generally going to be low, and we really don't have to treat these kids. But if the stomach is loaded with evidence of heavy metals within the stomach, now you have a problem. There have been no reported iron poisoning from the liquid preparations. And the reason is, okay, if anybody ever tried to give a kid um, ferrosulfate, okay, ferronsol drops or liquids, the stuff stinks to high heavens. It smells like rusty pennies. You have to hold the kids down to give it to them. No kid is going to voluntarily drink this stuff when he basically takes the smell of it. He's not going to drink it. So if the tablets more than the liquid, that's the problem. Um, Basically, if you suspect iron ingestion, you do serum iron, especially if it's 4 hours after ingestion, because that's where the peak level of iron is going to be. If your serum iron is less than 500 micrograms per deciliter 4 to 8 hours after ingestion, the risk is very low. If it's above 500 milligrams per deciliter, this indicates severe toxicity, and these kids have to be treated. In addition to doing the iron levels, you want to monitor the PTT, electrolytes, liver, and kidney panel, and then do gastric lavage on these kids. Well, basically, the kid has, chewed up tablets. He hasn't chewed them completely, so the tablets are too big. They're not coming up through a nasogastric tube. So gastric lavage is basically ineffective, as is activated charcoal, because activated charcoal does not work for heavy metal poisoning. The thing that may work if it's there a significant amount of ingestion is whole bowel irrigation, meaning uh, polyethylene glycol. And if you're using that on small kids, you have to start an IV, because if you give large doses of polyethylene glycol to get more fluid in the GI tract, you may dehydrate them and kill them that way instead of with the iron poisoning. And then if there's a high dose, we use IV desferoxamine. Desferoxamine is a chelating agent, okay? And if you give it, it's going to turn the urine brick red. And that's how you know the iron is being chelated and excreted. And in the dark ages, we couldn't get serum iron levels, okay, from the lab very easily. So all we did was monitor the urine, okay? And we had a rack with IV tubes. And every voiding, we put them in the IV tube. And when the urine went from brick red to the color of rosé wine, Van Rosé, then we knew all the iron was out of the system. It was chelated. Now we monitor the iron level rather than just collected urines. So that's iron intoxication. Then we got the hydrocarbons. And hydrocarbons are in thousands of commercial products. But the toxicity of hydrocarbons, okay, depends upon the particular nature of the hydrocarbon. Basically, it's viscosity. So, if we talk about low viscosity hydrocarbons, which are the biggest problem, aspiration pneumonia is low support and toxic effect. But the proportion of aspiration is directly inversely proportional, okay, to its viscosity. The low viscosity hydrocarbons are the big ones. High viscosity hydrocarbons, no problem whatsoever. So what's a low viscosity hydrocarbon? Okay. Mineral spirits, naphtha, kerosene, gasoline, lamp oil. These are very low viscosity. They spread rapidly across the lung due to aspiration and cause severe aspiration pneumonia symptoms. And this is the most common cause of deaths in the pediatric patients, is with low viscosity hydrocarbons. The aromatic hydrocarbons, you remember those? That's from your organic chemistry lab, all the ones that gave that smell to the organic chemistry lab. We're talking about benzene, toluene, xylene. Okay, the symptoms of these are usually by inhalation, but they also can occur by ingestion or direct contact with the skin. These may result in aspiration pneumonia, but lower because the risk is lower because their viscosity is higher. So if you swallow them, okay, you can get dysrhythmia and sudden death as a result of myocardial sensitization. Many of them have anesthetic properties. It could cause CNS damage. So that's the next low viscosity hydrocarbons, the aromatic hydrocarbons. Then we have high viscosity hydrocarbons. What's the most common high viscosity hydrocarbon that you have in the house? It's used on the skin. Vaseline. It's called petroleum jelly. Okay. Mineral oil, motor oil. Okay. These are the high viscosity hydrocarbons. They have no toxicity at all. I mean, we used to use mineral oil to treat constipation. We used to give a tablespoon of mineral oil per year of age, okay? Because it wasn't absorbed. It just went through the GI tract and it lubricated the stool, and out it came as they leaked mineral oil out of their butt. Okay, so if kids eat petroleum jelly, no problem whatsoever. It's not going to give them any issue, basically, at all. Okay, then we have chlorinated hydrocarbons. Okay, you know the most common chlorinated hydrocarbon? Carbon tetrachloride. What do we use carbon tetrachloride for? And it's very common. Okay, carbon tetrachloride is used as a spot remover on clothes. You know those little spot removers that they sell to take spots out of your clothes? That's carbon tetrachloride. Okay, that's why it works. Okay, and basically it can cause hepatic toxicity if it's ingested. And the other one there is benzene exposure. We know that prolonged exposure to benzene can trigger acute myelogenous leukemia is reported with exposure to that. Okay, nitrobenzene and aniline methemoglobinemia has been reported with those. So hydrocarbons can be a problem, but the biggest problems are the lowest viscosity and the semi-low viscosity hydrocarbons. Clinical manifestations, if it's aspiration, we get aspiration pneumonia, may cause mild CNS depression, okay? And when you take x-rays on patients who ingested low viscosity hydrocarbons, their initial x-rays are negative, even though they're coughing their brains out, okay? The respiratories may be mild, depending upon the degree of ingestion, or may progress to acute respiratory failure. So, how do we treat these? The only thing we can do is supportive therapy. We do not do emesis or gastric lavage on these patients. If it went down without aspiration, you don't want it coming back up for a second try. Activated charcoal, once again, is of no benefit, just as it is with heavy metals. It is no benefit in aromatic hydrocarbons. Steroids are of no help in treating basically the aspiration pneumonia. Okay, and likewise, antibiotics are not indicated since the risk of pneumonia in most cases is small. We don't put them on steroids or antibiotics. Now, this one you will see, and this has become a lot more common: calcium channel blockers. Okay, you took pharmacology, you know all about calcium channel blockers. You know they come in both immediate release and sustained release tablets. Okay, they're being used as cardiac medications. Okay, and of course, as the risk of use goes up, the risk of poisoning goes up along with it. The toxic effects are basically an extension of the therapeutic effects. There's a very narrow therapeutic window. So if you take more than is necessary outside the therapeutic window, okay, there's myocardial and smooth muscle response resulting in cardiac arrhythmias and hypotension. Now, depending on the product that's suggested, the presentation of symptoms may be rapid within minutes or delayed if it's one of these sustained release tablets. And basically, the symptoms are bradycardia, varying degrees of AV block, hypotension. That myocardial depression can result in shock. Occasionally, because of the hypotension, you can wind up with confusion, depression, agitation, lethargy, maybe coma. Hypoglycemia may present with these also, but serum calcium levels remain normal. So the message here is any kid who shows up in the emergency room with the acute onset of hypotension and bradycardia has calcium channel block poisoning until proven otherwise, because that will be the most common presentation of a kid who comes in with hypotension or bradycardia. And basically, the only thing you can do is supportive care, maybe activated charcoal if it's recent. But if they ingested some of these sustained tablets that grandma or grandpa is using, because that's where they usually get it from, okay, then whole barrel irrigation to wash out any that may still be in the GI tract that haven't broken down and been absorbed yet. So basically, that's how we treat them. And the last on the next to last on the list is caustics or corrosives. So we have acids, which is defined as anything with a pH lower than 2. Anybody know what the pH of Coke is? Coca-Cola? What? Anybody know what the pH of Coke is? The pH of Coke is 3. Yes. In the dark ages, when we had radiators that didn't have year-round antifreeze, and in the summer your car overheated because the car got rusty and obstructed the outflow of the radiator, and steam was coming out of your radiator, you drove into the gas station, the mechanic said, give me a dime, because that's what Coke cost at the time, and he bought a bottle of Coke and poured it in your radiator. And it ate through all the rust that was in the radiator, causing the overheat. Then he washed it out and you went on your way. So that's what Coke is, Coca-Cola, okay? Um, so basically, acids are defined as pH less than 2. Well, where do we find acids in the house? Well, hydrochloric acid is in toilet bowl cleaners. You know, those lovely blue color that cleans your toilet bowl? That's hydrochloric acid. Also in mold and mildew cleaners, and in swimming pools. That's the stuff that's in swimming pool cleaners to keep the pool clean. Acetic acid is in food pickling, which you don't usually see, but anybody who develops their film at home is using acetic acid there. Oxalic acid is a metal polisher. Phosphoric acid is used to remove rust. And sulfuric acid, okay, is in the lead batteries in your car, and again in drain openers, okay, to clean out your drain. Then we have alkalis, pH greater than 12. Why do we use alkalis? Because they digest and dissolve proteins, causing liquefaction necrosis. So dissolving proteins in your sink, if you swallow it, it's going to dissolve the proteins in your GI tract. Aluminum hydroxide is a grease remover and general cleaner. Sodium and potassium hydroxide, drain openers to open up the drain, like Drano, okay? Or grease removers, you know, like what you use to clean the grates in your oven, okay? When you spray it on your oven, that's either sodium or potassium hydroxide. And sodium hypochlorite is what you chlorinate your water with, okay? That's the chlorine in the swimming pool is sodium hypochlorite. So it goes in powder or tablet form, okay, and dissolves and gets diluted down. But if you ingest the powder without this dissolving, it is a significant alkali. Other caustics that are available are cationic detergents, your laundry detergent capsules, or your dishwasher capsules. You know, we talked about the pod challenge that these idiots are doing. That's the cationic detergents. Hydrofluoric acid is what they use for rust or graffiti removal. Okay, phenol and zinc chloride are also out there as caustics. So that basically, when we're talking about caustic ingestions, okay, 1,000 children are hospitalized every year for the ingestion of some caustic. The average hospital stay is about 4 days. That means kids getting into caustics cost your insurance companies $22 million a year. Okay. When I was a resident, we had a kid that ingested Crystal Drano. which was a disaster. And he came back on a regular basis because after the ingestion, he would develop esophageal strictures and would come in and have to have his esophagus dilated on a regular basis because the strictures would reoccur, and eventually they removed his esophagus and they took a portion of his bowel and replaced it because he couldn't just deal with it anymore. That's how bad caustics are. Okay, the clinical manifestations are based upon contact with skin, eyes, and the GI tract, and we divide them into immediate response, delayed response, and then the remote manifestations. So the immediate response is basically pain and loss of function. Okay, there's swelling of the tongue, there's drooling, there's vomiting, there may be burns in the oral mucosa. If it's down into the airway, you can wind up with stridor and respiratory compromise. It can perforate the esophagus, resulting in mediastinitis, okay, or perforate the stomach and bowel, resulting in a peritonitis. These are not easy things to deal with. They are very nasty. Okay, the delay in the distance, okay, if the patient survives, there may be dermal and ocular scarring or esophageal strictures, like I said, with pain, with swallowing, dysphagia, malnutrition, maybe carcinoma or pyloric stenosis later on. So, no emesis, no lavage. If it got down there, basically, we leave it there. We don't try and bring it up again. Okay, immediate evaluation of the airway to make sure there's no stridor or no laryngeal or cord burns. Okay, so basically on your physical exam when they come in, you look for burns of the lips, oropharynx, because if there's burns of the lips and oropharynx, there's probably burns further down in the GI tract. Even in the absence of burns, don't feel too confident because 30% of the ingestions don't have burns of the lips and oropharynx and still have GI injuries. Okay, if you know the ingestion is an acid, immediate endoscopy. You do not wait. Get somebody to take a look down the esophagus, the stomach, visualize the cords to see what's going out. If it's an alkali burn and they're asymptomatic, no symptoms whatsoever, no burns in the GI tract, nothing, you hospitalize them and observe them for 4 to 6 hours. And if they're symptom-free, you can send them home. If there's drooling, vomiting, or refusing to drink, NPO overnight. Somebody will say, give a milk to neutralize the acid or the alkali. One problem with that, because if they've perforated their esophagus, you're pouring milk into their mediastinum or their peritoneum. So you keep them NPO overnight. You do not give them milk right away to neutralize it, okay? And then you can, if their symptoms abate overnight, then maybe you can try liquids. If there's stridor in these patients, they get an immediate endoscopy also, okay? All acids get immediate endoscopy. Alkali, if they're stridor, they get an endoscopy. Okay. Any ingestion in a patient over the age of 5, that means it was intentional. They knew they shouldn't be doing it. They go for immediate endoscopy, whether it's an alkali or an acid. Do not wait. You do an endoscopy on those immediately. And the last thing we include in poisoning is vitamins. Okay. And we bring it up because in today's society, there's mega use of vitamins. People are taking high dose of vitamin C, okay? And you take high dose of vitamin C to prevent colds. You have the healthiest commode in the neighborhood because any excess vitamin C, you pee right out. It does not have long-term effects, okay? The ones you have to worry about are the fat-soluble vitamins. Vitamin A and vitamin D, those are the two we worry about, okay? And in small infants with excess intake of vitamin D, they may present with bulging fontanelles, evidence of intracranial pressure. The other kids we worry about are mommy has a baby and she's breastfeeding, and we give them the baby vitamin D drops there because there's no vitamin D in breast milk, and the dose of vitamin D is 400 international units a day, and the vitamin D that comes in is called D drops. One drop on the tongue is 400 milligrams. Well, if the older kid gets jealous, the baby's getting this, I can drink it. If one drop is 400 units, and he finishes the bottle because, why not? Okay, high dose of vitamin D can cause problems in old children, and the symptoms include anorexia, increased thirst, frequent urination, maybe abdominal muscle and joint pains, and maybe renal damage. So you have to tell mom you got to give the baby the vitamin D, not in the the vision of the older child, so he sees what's going on and he wants it. We want to prevent vitamin D intoxication in the older child, and that's how the kids with vitamin D intoxication present. Okay, that's the end of poison. So the rest of the time here, we will talk about cardiology. Okay, and we were talking about the newborn, and I said I was going to talk about fetal circulation and nausea. Okay, this is what we're going to talk about. This is fetal circulation of the newborn. So the baby's oxygen is at the placental level, and the oxygen saturation at the placental level is 65% saturation of oxygen. Okay, if you had a 65% O2, what would you look like? You'd be purple. You'd be the color of my pants. Okay, you can't survive with an O2 sat of 65%. So how does the baby manage with an O2 sat of 65%? Your hemoglobin has a greater affinity for oxygen at low oxygen tension. Okay, so the blood gets oxygenated here, and then it's carried back, bypassing the liver. Okay, blood vessel is carrying the oxygenated blood back to the placenta. What blood vessel carries the oxygenated blood back to the placenta? On the umbilical what? Vein. The umbilical vein in the baby carries oxygenated blood. There's only one other vein in the body that carries oxygenated blood. Pulmonary veins. Okay. So something very interesting happens, okay? When the oxygenated blood returns through the inferior vena cava into the right atrium, studies have shown that the oxygenated blood flows across the foraminal valley into the left ventricle and up into the head. So that basically the developing brain gets the most oxygenated blood, okay, at all, in the baby. The blood from the coming back from the head, okay, and the rest of the body goes into the right ventricle, goes out the pulmonary artery, okay, and then where does it go? Does it go through the lungs? No. Why not? What?
Not developed.
Or not necessarily not developed. They're collapsed. Blood flows from a higher pressure to a lower pressure. If the developed lungs are collapsed, there's high pressure in the vascular bed. So where the heck does the blood go? The blood goes from the pulmonary veins, okay? I mean, from the pulmonary artery through the patent ductus arteriosus into the descending aorta. Okay, so the blood coming out the pulmonary artery, okay, bypasses the lungs and goes directly into the descending aorta. That's fetal circulation. Okay, then we deliver the baby, and what's the first thing we do when we deliver a baby? What? Say it.
What's in the upper scale?
No, what's the first thing we do when we deliver a baby? We cut the cord. We separate the baby from the placenta. Now, the thing you have to remember is the placenta is a low pressure organ. Just a big sack of blood vessels, nothing much. When we cut the cord here and we remove this low pressure organ, we're increasing systemic pressure all of a sudden because we removed this low pressure organ. So if we're increasing systemic pressure, okay, then we're increasing systemic pressure in the aorta. And if we're increasing systemic pressure in the aorta, then we're increasing systemic pressure in the left ventricle and left atrium. Okay. Well, if we increase systemic pressure here in the left atrium, the foraminal valley closes, just due to the fact that we cut the cord. Okay. In addition, what does the baby do when we deliver the baby? What? It cries. So what does crying do? The baby takes a deep breath. And when the baby takes a deep breath, it opens up the pulmonary vascular bed, which means it's going to decrease pressure in the pulmonary vascular bed. So now blood, instead of flowing through the pulmonary arteries into the through the patent ductus into the aorta, now goes to the vascular bed. And the presence of higher oxygen saturation also decreases pressure in the vascular bed. So when you have decreased pressure in the vascular bed, more blood flows through the lungs, more blood comes back through the lungs. So that means there's more blood coming back to the left atrium, which increases the closure of the foraminal valley. And because of decreased pressure in the lungs, okay, blood starts, because blood flows basically from a higher pressure to a lower pressure. What's normal? What's the normal pressure in the aorta? What's normal aortic pressure? Take it on every physical exam.
120.
120 or 80. It's, whether it's systole or diastole, it's either 120 or it's 80. It's one of those. What's normal pulmonic pressure? In the pulmonary artery. 25. Okay? You do not need a lot of pressure to push blood through the lungs. So, okay, when the lungs are collapsed, there's higher pressure in the pulmonary vascular bed, blood flows through the patent ductus, okay? All of a sudden, the baby takes a breath, the pressure drops, so blood, instead of going through the ductus, goes to the pulmonary arteries to the lungs. Now, it can flow the opposite way. That's a potential problem if the ductus doesn't close. We'll talk to that in a bit. But generally, all the changes that occur, okay, from fetal circulation, okay, to normal physiologic adult circulation that we have are due to changes in pressure. That's all it is, okay? We remove the placenta, the baby takes a breath, okay? Vascular systemic pressure goes up, pulmonary vascular bed pressure drops, and that's how the changes occur from fetal to adult circulation. Okay, so this one's not going to work. Here's next slide. There we go. All right, this is a picture of the heart, and this is the all the pictures I'm going to show you, all the congenital heart diseases. Okay, so this is a right atrium, right ventricle, left atrium, left ventricle, main pulmonary artery, aorta, and the vena cava. Okay, if you really want a great toy to play with, there's an app called Heartpedia. It's from Cincinnati Children's Hospital. It's an app. It's free. It has all the congenital heart diseases in 3 dimensions. You can turn it 6 ways from Sunday, upside down, inside out, rotated. It shows you the external findings of the congenital heart disease, the internal findings, and what it looks like after surgery. So you can play with that. It's a great free app to look at. I mean, we're using static pictures here, but I mean, if you want to play with it, it's there. Okay. Everybody know what this is? This is clubbing. Okay. Everybody realize it's clubbing? Okay. The next thing we talk about is this one. When we're talking about cyanosis. Okay. We talk about peripheral cyanosis and central cyanosis. Central cyanosis means you have hypoxia of some sort, and peripheral cyanosis, okay, means you're cold. So have you ever seen a kid who comes out of the ocean in the middle of the summer? His lips are blue. Do we worry about him because his lips are blue? Is he cyanotic? No, that's peripheral cyanosis. Well, in dark-skinned people, how in the world are you going to tell the difference? Okay? I mean, these lips sort of look blue, and he's sort of dusky here around the lips, but is that peripheral or ventral cyanosis? The way you tell the difference is to look at the tongue. If the tongue is as blue as the lips, that's central cyanosis. Those are the ones you worry about. If they're just the lips are blue and peripherally around the lips are blue, but the tongue is nice and pink, this is not central cyanosis. Okay? Okay, so we're going to talk about congenital heart disease, cyanotic heart diseases, and the acyanotic heart diseases. So the first one, okay, is the right to left shunts. If we're shunting blood from the right side of the heart to the left side of the heart, what do we bypass? The lungs. So right to left shunts are cyanotic heart disease. Left to right shunts are not. Now, God was good to you because every cyanotic heart disease starts with the letter T. If it doesn't start with the letter T, it is not a cyanotic heart disease. Tetralogy, transposition, truncus, tricuspid atresia, and total anomalous pulmonary venous drainage all begin with the letters T. ASD, VSD, coarctation, none of them begin with the letter T. They are not cyanotic heart disease. Okay? So, the first cyanotic heart disease that we're seeing, okay, is this one. Come on. So what do you see here on this page? What's abnormal on this page? Anybody? What? Oh, so there's an overlying aorta, okay? And what's this space right here? There's a hole between this side and this side. So there's an overriding aorta, a ventricular septal defect. There's narrowing of the pulmonary outflow and right ventricular hypertrophy. Four things. What is it? What? Tetralogy of Fallot. Okay? So this is tetralogy of Fallot. Okay? Ventricular septal defect, overriding aorta, right ventricular hypertrophy, okay, and pulmonic stenosis. And the pulmonic stenosis may be due to a pulmonic valve stenosis, okay. The valve itself may be narrow or the outflow tract, okay. Tetralogy of Fallot is the most common congenital malformation associated with cyanosis, okay. It is not the most common congenital heart disease. It's the most common congenital heart disease with cyanosis. 5 to 70% of all congenital heart defects are this. These patients may be acyanotic at birth. It depends on two things, okay? One, it depends on how bad the pulmonic stenosis is, or is there a patent ductus still open? Because even though if there's narrowing here, if there's a ductus open here, then there's blood flowing from the aorta into the lungs, so they may not be cyanotic initially, okay? So, when the ductus closes in the first few hours of life after birth, the baby may turn purple. In milder forms of pulmonic stenosis, okay, the cyanosis may not be very present at birth and gradually increases with growth and increasing infundibular stenosis. Now, typically, babies with tetralogy may have cyanotic spells, which occur in the first 2 years of life, which we don't see anymore because we fix these fairly early. I mean, in the bad old days, when we were doing cardiac surgery, babies could not be put on bypass. So we couldn't put them on bypass. We had to keep them alive long enough till they got big enough to put them on bypass. Now, within a year of life, they get fixed. These cyanotic spells, the baby becomes hyperpneic, means it begins to deep breathe more rapidly and deeper. They become restless, the cyanosis increases, they have gasping respirations, and they pass out. Usually this occurs early in the morning upon awakening or after crying, okay? And these patients murmur, okay? The typical murmur of these patients, okay, is a systolic ejection murmur, okay? It's a harsh murmur with a click radiating into the axilla and a single S2 with no splitting. This murmur disappears. Well, that sort of tells you what the murmur is caused by, okay? Is the murmur caused by the flow across the VSD? No. The murmur is caused by increasing in the pulmonic stenosis. And as the pulmonic stenosis gets worse and worse and worse, the oxygen goes down and down and down. The kid becomes hypertonic, blue, and passes out. It is rarely fatal, okay? And it may last for minutes or hours, okay? And the murmur disappears because the stenosis closes up. You don't hear the murmur because the murmur is the murmur of pulmonic stenosis, okay? In the bad old days, when kids lived longer, okay, they would develop clubbing of the fingers and toes and dusty mucous membranes. So we fix these kids pretty early now. Also, in the bad old days, if you watch these kids, okay, they'd be playing, and suddenly they stop playing, they squat down, then they get up and go back to play. What the heck are they doing? Why were they squatting down? What?
They're doing their own Valsalva maneuver.
Well, I mean, it's really not about salvo maneuvering, but physiologically, what is it doing? What?
Increasing.
Right. It increases blood flow back from the lower extremities to the heart. They figured out that if they increase, okay, blood flow back from the lower extremities, okay, to the right ventricle, you'd have a greater volume of blood in the right ventricle. It would overcome any stenosis that may be there and made them feel better. So they would basically figure it out how to improve saturation just by squatting down and increasing venous return to the right side of the heart. Okay. Now, the typical murmur, okay, we said was due to turbulence through the ventricular outflow tract. It was at the upper left sternal border, crescendo, decrescendo kind of murmur. Okay. The EKG, okay, has right axis deviation and right ventricular hypertrophy, because we said these patients have right ventricular hypertrophy because of the extra load pumping past the pulmonic stenosis. Also, and this is a board question, okay, if you take an x-ray on these patients, okay, because of the right ventricular hypertrophy here, the apex of the heart is lifted upward off the diaphragm, okay? And it creates an image that's called core ensemble or boot-shaped heart. In other words, the picture of the heart looks like the bottom of Italy. You know, the bottom of Italy looks like a shoe. That's what it looks like. And I guarantee you will probably see this. This is one of the favorite questions. The x-rays of hydrology is below. Core ensemble or boot-shaped heart. This is the x-ray finding on these kids. Okay? When you check the x-ray, the lung fields are clear because there's decreased blood flow going to the lungs because of the pulmonic stenosis. Okay, complications basically of this congenital heart disease, cerebral thrombosis, brain abscesses, or bacterial endocarditis. Currently, these kids get complete correction between 4 and 12 months of age. The bad old day, we couldn't do it, okay? But now, basically, they close the VSD, they correct the pulmonic stenosis. If there's a PDA, they close it, and they're done. Bad old days, we couldn't do it because we couldn't put them on bypass. So we did shunts. Okay, we connected the we can guess what? Just started. We connected the descending aorta to the right pulmonary artery. Okay, or we connected, the superior vena cava to the right pulmonary artery, or the descending aorta to the left pulmonary artery. And the surgeon just created a small shunt. We're talking about 5 millimeters. It's not a big shunt. It was just to increase the blood flow through the pulmonary vascular bed. If it was 4 millimeters, it didn't work. If it was 6 millimeters, the kid went into heart failure. So these were the ages of early uh, heart surgery on congenital heart disease. Now they go in and they just close the whole thing, and that's the end of it. So it's not. It's fairly rapid, and it's miraculous. I'm now in my practice. She's 18 years old. Okay, she had complete correction of her nephrology. She's besides the Down syndrome, she's perfectly normal. Cardiac wise. All right, what's wrong with this heart? What? Yeah, the vessels are switched. Just follow the blood flow from either ventricle. Is this compatible with life? No. This is transposition of the great vessels. This is the second most common congenital heart disease associated with cyanosis. About 5% of cyanotic congenital heart disease. It's more common in males than females, and more common in infants of diabetic mothers. Okay? And there's got to be some sort of opening here, right? Okay? There's got to be some sort of mixing, because if there's no mixing, the patient dies. So these patients either have an ASD, a VSD, or a patent ductus in order basically to survive. Okay? The more common ones are total transposition of the great vessels without a VSD. Most babies with transposition do not have a VSD. So these kids are purple at birth. And you give them 100% oxygen, and they're still purple at birth. Okay? Physically, other than the cyanosis, they look fine and dandy. Okay? Their EKGs and X-rays are normal. Okay? The murmur may be non-specific, it may be due to flow across the pulmonic valve, but that's it. If there's a VSD, okay, and it's small, it's the same as without a VSD. Okay, if it's large and there's significant mixing at the VSD level and the ventricular level, they don't turn so blue, okay, but they go into heart failure. And they have the murmur of the VSD rather than of the pulmonic flow murmur, so they have a holosystolic murmur. Okay, and their X-ray shows cardiomegaly and increased pulmonary vascularity, whereas the X-ray without a VSD is perfectly normal. So this treatment is urgent. Okay, they get fixed on the day of birth. As soon as they can put everybody together. As long as the ductus stays open, you don't have a problem. But the ductus normally closes at birth, so very often they would infuse prostaglandin 1 in an attempt to keep the ductus open until they can take the kid down to surgery. All right, so if you're a surgeon, how are you going to fix this? You're a surgeon, how are you going to fix it? Switch them. Unswitch and sew them together. That's how you do it, okay? In the dark ages, we couldn't do that because we couldn't put a baby on bypass. So the kid was bigger. So how do we treat these kids? The cardiologist would insert a catheter up the inferior vena cava through the foraminal valley, and he'd blow up a balloon, and he'd put his foot on the cath table, grab the catheter, and yank it as hard as he could to tear a jagundo hole in the center. That's the barbaric way we did medicine. Okay? And if we had mixing, they did fine. Okay? Well, then when we destroyed the intraatrial septum and they got bigger, we still couldn't put them on bypass. Okay? So then what did we try to do? It was called a muscle procedure where they took some pericardium, okay, and they created a tunnel from here across to the left ventricle, okay? But there's one problem with this. The right ventricle was not designed to pump the systemic blood pressure, okay? It was not designed to pump at up to 120 millimeters of mercury to do adequate vascularity. So then these kids subsequently required, heart transplantation because there wasn't much else we could do. Now, it's not now, because I have a patient in my practice who had transposition of great vessels, okay? And he is now 6 feet tall and has a kid of his own, okay? And when he used to come into my office, every student drew the diagnosis for two reasons. One, you never look at the medical record for a history. And my medical records, I still use paper. You don't go down and see 8 visits a page. And all you had to do is flip through it and say, transposition of great vessels, transposition of great vessels. Okay. The other thing is, you listen to the chest through the clothes. You never lift up the shirt. This kid's got a scar from the top of his sternum to his xiphoid, because that's how they did the surgery. They cracked the sternum, okay, opened his chest, and switched him. But nobody ever looked, so you never knew. And because once he's fixed, he's perfectly normal. Okay, so now that's the treatment of transposition of the great vessels within the first 2 weeks of life. Okay, before the left ventricular decreases and cannot provide systemic blood flow, they go in, they put them on bypass, and they switch them. That's it. Fix them, no problem. So that's basically transposition of the great vessels. Okay. Oh my God, what's going on? They didn't teach you they don't teach you embryology, right? You say, thank God they used to. Okay. All right. There's just one vessel there. Well, why is there only one vessel there? It says, remember embryology, so here's a quick lesson in embryology. Okay? The heart starts as a single tube, and then it becomes that shape. And then this part of the lower portion folds up behind the single tube on top. And then you have right atrium, left atrium, a single vessel called the truncus arteriosus, right, left ventricle. And then the primary truncus arteriosus is supposed to divide into a pulmonary artery and an aorta. And it doesn't. Okay? This is not very common. It's only 1 or 2% of all cardiovascular defects. And they almost always have a VSD. They almost always have a VSD because they got this trunk overriding both vessels. Okay? So the clinical manifestations basically vary with age. Newborns, minimal cyanosis, maybe there's a thrill and a systolic ejection murmur. As they get older, they go into heart failure. Still with minimal cyanosis because you get adequate mixing of blood flow to both systems. Okay, there's a systolic ejection murmur with a loud single-second heart sound. And as they get older, they develop progressive cyanosis, polycythemia, and clubbing. Why? Why do they suddenly get cyanosis, clubbing, and what happens? What?
Do they not require hormones?
No, that's not why it happens. What's the pressure in that single vessel? What's known as systemic pressure? 120. What does the lungs expect the pressure to be? 25. So these patients develop pulmonary hypertension. And once they start developing pulmonary hypertension, it's not reversible because the excess pressure flowing through the lungs, okay, if they develop pulmonary hypertension, okay, Then they start developing all the signs of pulmonary hypertension, meaning they become cyanosis, polycythemia, and clubbing because of the development of pulmonary hypertension. So that's the problem with this. So they have to fix this between 4 and 6 weeks of age before the pulmonary vascular disease begins. So they do what's called a Rastelli repair. Basically, they close the VSD. Okay, they close the VSD, and now you got a right ventricle going nowhere. Okay, so then they make a conduit from the right ventricle. Okay, basically, to the pulmonary arteries. Okay, in other words, they chop the pulmonary arteries off this, the pulmonary artery off this single root, and they make a connection from the right ventricle to the pulmonary arteries with a homograph. Now you got blood flow going from the right ventricle through this. Yeah.
But pulmonary arteries don't have, like, you're saying they just take that, those, like, pulmonary arteries from there, they don't have like a valve.
They cut them off the trunk.
Then isn't it just gonna constantly be open if there's no valve or something?
Yeah, when they give you homographs, the homograph comes from here out to the pulmonary arteries. And it doesn't necessarily need a valve, basically, okay? Because once again, it's a low pressure system, so it's not a big problem. The big problem is we're doing this at 4 to 6 weeks of age. How big is this kid's heart in September? How big is your heart? It's not the size of your fist. So imagine doing surgery on the size of the newborn's heart, okay? So they put a hole in the right ventricle, okay, and they connect a tube from the right ventricle to the pulmonary arteries. Except what happens? What do kids do? What? They get bigger. So the shunt that the homographic shunt that they create has to be replaced periodically in order to deal with the conduit that they made has to be replaced because the kid gets bigger. So you need a bigger conduit as the patient grows. Fortunately, this is not very common. Okay, what's wrong here? Start from the superior vena cava. Where does it go? Superior vena cava to the right atrium. Then where does it go?
Left atrium.
Goes to the left atrium. How come?
No,
What's missing? The tricuspid valve is missing. There's no tricuspid valve here. This patient has tricuspid atresia. Okay? This is extremely rare. And in 50 years, I've only seen two. I have one in my practice now, and I saw one when I was an ICU fellow. Okay? So one every 50 years, it's not very common. All right? This is a rare congenital heart defect. Okay? There's no outlet from the right atrium. All right? And the systemic return enters the left side of the heart through a foraminal valley or an atrial septal defect. This may be present at birth, okay? And if there's no VSD, then they're purple at birth, no question about it. And again, it depends upon the size of the VSD, okay? The patient I saw when I was an ICU fellow was, of course, a doctor's kid. He was a pediatric neurosurgeon. He comes up to me and says, my week-old baby seems to be having difficulty. The respiratory rate is 80 and the heart rate is 200. I said, your baby's in heart failure. Bring them into the hospital. Okay? This was the atrial septal defect. Okay? Basically, there's a holosystolic murmur and a single-second heart sound. 85% of these are diagnosed by 2 months of age. This is the only congenital heart disease that I've mentioned that has left ventricular hypertrophy. Okay, all the others have right ventricular hypertrophy. This one has left ventricular hypertrophy. Okay. And the treatment, how do we keep pulmonary blood flow adequate? Newborns with severe cyanosis, we give them prostaglandin D1 to keep the ductus open, so at least there's some flow from the aorta through the pulmonary arteries into the lungs. Okay? The problem with that is pulmonary hypertension, because if the ductus is open and you're keeping it open, you're going to have blood flow at a higher pressure going to the lungs. That's a problem. Okay? If you're watching these kids, okay, and basically the VSD stays open, well then basically it stays big enough, you can get some blood flow to the pulmonary artery, okay? And if there's adequate blood flow, the baby may not become that cyanotic till the VSD spontaneous closes, and then you have a problem. So basically, they don't wait. Okay? The current treatment now is to create an anastomosis, okay, from the right atrium or the inferior vena cava to the pulmonary arteries. They do, the kid in my practice now had what's called a Blaylock Taussig shunt. In the bad old days, the Blaylock Taussig shunt was the one that basically, I said, we create a hole between the superior vena cava and the right pulmonary artery. Okay, they created a hole. Now they use cadaver, vessels, and basically all they do is they connect the inferior vena cava to the right atrium. I mean, not the right atrium, the pulmonary artery. Okay, so that you don't need much pressure. All they do is they're connecting either the right atrium to the pulmonary artery or the inferior vena cava to the pulmonary arteries with a shunt, and this kid's doing fine. Now, the shunts have to be replaced. These kids may go into heart failure, okay? So somebody will say, well, why just can't put a valve in? Right? Wouldn't that make sense? Put a valve in? No, putting a valve in doesn't make sense, basically because this right atrium has not been pumping a great deal all through fetal life. And because it hasn't been pumping all through fetal life, it's hypoplastic. So putting a valve in is not going to do much good because you run into all the risks of a valve in the heart, okay? And the pumping outflow of the right ventricle is not going to be adequate enough to pump blood through the pulmonary vascular bed. So instead, they just use these existing pressures in the right atrium or the vena cava, creating a shunt and giving oxygen to the lungs, okay? Fortunately, it's not very common. The last one, oh my God. Follow blood back from the lungs. Where is it supposed to go? Oh wait, this check. Blood comes back to the lungs. Where's it supposed to go? Left atrium. Where's this blood going? Anywhere but the left atrium. It's taking a right turn and going up into the superior vena cava. This is total anomalous pulmonary venous drainage. Fortunately, this is extremely rare. Okay, the heart has no direct pulmonary venous connection to the left atrium. It may empty into the right atrium, coronary sinus, superior or inferior vena cava, or the portal vein. It's just not going back to the left atrium. Okay, and there are three basic patterns. One is in the newborn period, there's severe obstruction to the pulmonary return. So these kids are cyanotic, tachypnea. They have no murmurs, and you give them 100% oxygen, they'll get better. In the mild version, okay, there's moderate obstruction pulmonary return and a large left to right shunt, okay, probably through the an AFB, okay, and they go into heart failure but only have mild cyanosis because there's an adequate return of blood from the lungs, okay? but they may go into heart failure with a gallop rhythm. Okay. And if there's no obstruction to the pulmonary venous return and a large left to right shunt, they don't develop pulmonary hypertension. They're not cyanotic. The only person I have ever seen with this, okay, is the father and grandfather of my patients. They diagnosed this when he was 65. So it meant he lived his whole life. Nobody took an x-ray. Nobody looked. Nobody saw it, okay? He was reasonably healthy his entire life, and then all of a sudden started to have symptoms, okay? And he had corrections when he was about, I think, 60 or 65 years old. And the surgeon did the surgery for free because he could publish it, okay? He can publish this case because it's a real rarity. How does somebody live 65 years old with a congenital heart disease that everybody missed? Apparently, he had adequate flow, never got cyanotic, okay? He wasn't a great athlete, so he never got short of breath or anything else. He was relatively thin, okay? Did fine. He's still alive now, so, and he's in his late 70s, early 80s, okay? So again, this is very, it's not very common. And basically, once again, you just hook up the pulmonary vein to the left atrium, close the ASD, and you're done. So it's not a bad surgery to do. Okay. They don't develop pulmonary hypertension because nowhere do they get a higher blood flow going through the lungs. So these patients do reasonably well. Okay. Those are all the cyanotic heart. Okay. Then we go to the left to right shunts. Notice none of them begin with the letter T. So if it's acyanotic, okay, we're talking about left to right shunts. And the first one we're talking about is a patent ductus arteriosus. Okay. Patent ductus arteriosus. Second most common cardiovascular defect. Not the second most common cardiovascular defect associated with cyanosis. The second most common cardiovascular defect, 8 to 10%, 6 to 8% of the patients have those with congenital heart disease have this. It's more common in females than males, and it's much higher in premature infants. Up to 20% of premature infants have patent ductus arteriosus. And in the bad old days, we saw all of these in rubella babies. Mother who had rubella during their pregnancy, a lot of their babies had a patent ductus arteriosus. Okay? The reason it's so common is it's 10% of all the congenital heart diseases we talked about. We talked about having a patent ductus, which helped protect the baby from significant cyanotic disease. Okay. Again, what's the problem? We talked about the problem. Because there's greater flow from the aorta into the pulmonary artery and the pulmonary vascular bed, these patients are at risk of developing pulmonary hypertension. Okay. And, there's also an increased load on the left ventricle because now it's pumping blood to both systems. If it's a small PDA, these patients are asymptomatic. They can walk around with a PDA for their entire life with no issues. If it's a large shunt, they may go into heart failure early in life. Most kids are in between small and humongous. These patients have the classic murmur of a patent ductus is a continuous machinery murmur at the second left intercostal space, left upper sternal border, radiating to the back, and maybe with a palpable thrill. Okay. And it obscures S1 and S2 because you can't hear it because you got a factory going on. What do we mean about a machinery murmur? Well, normal murmurs are most of them are during systole. Right? That's a normal murmur. Well, we talked about the pressure in the aorta and the pulmonary artery. So, if the systolic pressure in the aorta is 120 and it's 25 in the pulmonary artery, blood flows. If it's 80 in the aorta and 25 in the pulmonary artery, blood flows. So your murmur is more like shh, higher during systole, lower during diastole, but nonstop. So you get a shh. That's the kind of murmur. That's why they call it a machinery murmur. They also get bounding peripheral pulses. Okay? Why do they get bounding peripheral pulses? I mean, if the normal palpable pulse is something like when you're feeling a kid with a patent ductus, it's more like why. This goes right back to physiology. You got a leak in the aorta. During systole, it's 80. During diastole, this is 120. During diastole, it's 80. But there's a leak. So it doesn't stay at 80 because it's continually leaking into the pulmonary arteries. So maybe it drops from 80 to 60. What does the ventricle have to do to get that blood pressure back up? It has to constrict harder. You need a greater, I think it was called Starling's law way back in physiology, where you needed a greater pressure response in the left ventricle to respond to a lower pressure within the system. So you get bounding pulses in a patient with a patent ductus because he's got a leak in his aorta. So when the pressure drops to 60, the left ventricular contraction has to contract harder to get it back up to 120 where it's supposed to be to maintain its normal blood flow. So that's why these patients get bounding peripheral pulses, meaning a wider pulse pressure. EKG in small shunts is normal. In big shunts, we now have left ventricular hypertrophy or left and right ventricular hypertrophy in the really large shunts. What are the complications? Okay, cardiac failure, bacterial endocarditis, pulmonary hypertension. Talked about why. Okay, and the treatment of these. Okay, these kids do not need surgery. Basically, all they do is they pass the catheter up on the aorta, they pass it through the patent ductus, they open up an umbrella sort of contraption, okay? They pull it tight, disconnected, ductus closed. No surgery. Done in the cath lab. In the bad old days, in the neonatal ICUs, these kids with big ductuses would go into heart failure. So they didn't even take them down to the cath lab. They just brought them in, rolled them over on their right side, opened up their left side of the chest, closed up the ductus, sewed them up, and that was it. So now that's what we used to do in the dark days. Now the question is, how soon should you treat or ligate a ductus in premature babies? Okay, and they said now the study has shown that early closure of the ductus early on had worse outcomes in preemies than it did in waiting 2 weeks before you did the closure. So I guess they're not closing it as soon as we did. They had a higher risk of mortality doing the closure within the first few days of life rather than waiting 2 weeks before we did it. So that was the patent ductus. Okay. Now we have the ASD or atrial septum. 6 to 8% of all congenital heart defects. Generally, when we talk about the atrial septum, we talk about the ostium primum and the ostium secundum. The ostium primum goes up from the endocardial cushion. It goes up this way. The ostium primum goes down this way. And the defect is usually in the ostium secundum. It may be a single foraminal valley. It may be fenestrated. Okay. And again, these kids are asymptomatic unless the defect is huge. Okay. But even if it's huge, these kids are relatively asymptomatic. Younger children may have subtle failure to thrive. that's not usually picked up on. The way you usually pick up on an ASD is the patient goes to middle school, wants to play in sports, okay? So they go to for a physical. During the physical, you hear a grade 1 to 2 murmur. We'll talk about what grade 1 to 2 murmurs mean. And very often it's considered a grade 1 to 2 murmur. It's an innocent murmur. It's no big deal, okay? And where is the murmur occurring anyway? You think the murmur is occurring through blood flow through the foraminal valley or the ASD? No, the pressure's too low here. They're not here. So where do these kids hear a murmur from? Well, if there's blood flow from the left atrium to the right, there's more blood in the right atrium, which means there's more blood in the right ventricle. So the murmur you're hearing is a pulmonic flow murmur. Okay, blood flowing, extra blood flowing out through the pulmonic valve. Well, that's an innocent murmur, folks. Okay, that's what pulmonic flow murmur is, one of the innocent murmurs. So how the heck do you know the difference between a kid with an ASD, okay, or is this an innocent murmur? Okay, the ASD is better heard when the kid is standing up. Okay, the innocent murmur or Still's murmur is heard best when the kid is lying down. So that's the first clue. If you're training for sports and you hear a murmur, listen to it lying down. If you hear it just there, it's innocent. If when he's standing up, okay, you hear it, it's an ASD. Okay? And then these kids have a fixed split second heart sound. You know what a fixed split is? Do you know what a split second heart sounds like? Everybody knows what it sounds like?
Yeah.
Yes, okay. So this one's fixed, meaning it's there during inspiration and it's there during expiration. Normally, to get a fixed split second heart sound, okay, you tell the patient to take a deep breath, and then you hear splitting, and then he breathes out, and the splitting disappears. So these kids have a fixed split second heart sound. So if you hear a murmur with the kid standing up, you can call the cardiologist and say to the cardiologist, hey, I got a kid with a grade 2 murmur, best heard standing up, and he has a fixed split second heart sound. I think he has an ASD, and you'll sound like a genius. Because that's how the diagnosis is made. Okay? The EKG may show an RSR prime and maybe right ventricular hypertrophy. Rarely these kids go into just heart failure because you pick it up early in their 30s or 40s. They may go into heart failure. Hopefully, somebody's made the diagnosis before then. They may later on develop pulmonary hypertension as well due to the increased blood flow through the right ventricle with maybe increased pressure there. Okay, these patients are not at risk for bacterial endocarditis, and we'll tell you why. Do these kids need open heart surgery? No. Basically, what they do is if there's a defect, they can pass a catheter up through the foraminal valley, open up this umbrella contraption, pull it tight, disconnected, bingo, ASD closed. And I've seen pictures where they closed multiple holes in the intra-atrial septum, doing it the same way with a catheter. So once again, we're putting the poor cardiac surgeons out of business. We're doing all these closures in the cath lab rather than in the OR. Okay, it's 20 after. Take 10 minutes, and I'll come back and finish the rest of the talk.
Why? Where they decide that kind of so yeah. I would be like, yeah, I don't think I still don't party transplant. I'm like, man, I don't know. I don't know. I wish we were starting I'm trying to say. I feel like from yesterday. Oh yeah, I didn't know. Yeah, right. Yeah. I was like shocked. Before the quarters, they're like two quarters. Really? Like that. So going to him really. Like, yeah. Oh, which one? Yeah, this is like direct deposit. Like, it's so much worse than it's oh, then it goes going down. You have to going up. Yeah, going up. I know. The video that's slowly like just speaking up. I don't. So the rest of the guys. Yeah. It's just laughing was good. Oh, here's another. Oh, she's dude, what happened? So dangerous. Yeah, you're gonna Yeah. Yeah, of course. No, things that are fine. Right, that's all many. No, we can find out. You can go back to right. So we have this. We have this. I read it like last week. Oh, perfect. Spending that at yours. Yeah. We're spending that at your point. Whatever.
It doesn't matter. Like an action for I yell at him and I tell him it's really annoying. And then he try to like talk to me or something. But like I could go up there. Yeah, like I've been my Saturday. I also like yeah. We're all like laugh doing stuff with like guys made it for the like I'm still out today. I'm still here from some like before like my friend Jackson asked him like I'll sit in the corner like on like a lounge chair and like lay down and like hour hour
Yeah, we will love to go. One not that horrible. I don't know brother guy. I don't know about the
Did you get like
No, I did the water.
Yeah. That'll help you in that. Premiums, and that got worse.
we're in most
So,
and then my friend around the house.
If you need a price, yeah, the practice would be so long.
That's what they I would try to do that. Get all the eye openers. Like
Yeah.
Is it that I just know?
I really design things on
okay, hello.
This semester too, what's it new?
I'm gonna run over.
Yeah.
I have no place to go. That's not true. I gotta go to the office. Okay. Hey, hello. You want to talk? Go out in the hall. Okay. So now we're going to talk about the ventricular septal defect. This is the most common congenital heart. 25% of all congenital heart defects are associated with the VSD. Oh, all of a sudden it came on. Now it's too bad. Okay. Can you hear me now back there? Yes or no? Hello? Can you hear me?
Yeah.
Okay. All right. So the VSD is the most common cause of heart murmurs in the newborn. Okay. The most common defect is in the membranous portion of the septum. Okay. Muscular portion, membranous portion. The majority of them are in the membranous portion. And the clinical manifestations depend upon how big the hole is. Okay. And the pulmonary blood flow and pressure. So, what is it? The bigger the hole, the louder the murmur, or the smaller the hole, the louder the murmur? Smaller the hole, the louder the murmur. You can't whistle with your mouth wide open. Okay? Smaller the hole, the smaller the murmur. In the newborn, the murmur begins on day 2, 3, or 4. It's not present at birth. So if you're seeing a 3-day-old, 4-day-old infant who's got a grade 3 murmur, your first response is, oh my God, why did they hear this at birth? Okay, that's not your first response because it wasn't there at birth. Why wasn't it there at birth? What?
because the parental wallet.
Why would the foraminal valley have to do with the VSD? The problem is, blood flows from a higher pressure to a lower pressure. And normally, left ventricular pressure is 120/80, right? Ventricular pressure is 25. Except, remember we said when the baby takes its first breath, the blood flow through the pulmonary vascular pressure drops. It doesn't drop to normal on day one. It takes 3 or 4 days for that pressure to gradually drop. So the pressure in the right ventricle is going to be higher than normal, basically because it's pumping against a vascular bed that hasn't completely opened yet. Okay? So even if there's a ventricular septal defect, even if there's a ventricular septal defect, okay, there's not a great deal of high flow because the pressure on the right side of the heart is still somewhat high, so you may not hear the murmur. Then as the lungs are exposed to more oxygen, the greater the oxygen saturation, more vascular dilatation, more drop in pulmonary pressure. Then there's a larger gradient. With the larger gradient, then you basically hear the murmur. Okay? With a small VSD, with a trivial left to right shunt, and normal pulmonary artery pressure, that's the most common. These kids are asymptomatic at birth with a normal physical exam. But because it's a small hole, there's a loud, harsh murmur, okay, because it's a small hole, okay, holosystolic or pansystolic at the lower left sternal border. There may be a palpable thrill or an apical rumble. The EKG is normal, and 30 to 50% of these close spontaneously by 4 years of age, particularly if it's in the membranous portion of the septum. 85 of the membranous portions of VSDs close. Okay, in the muscularis, the lower number of spontaneous closure, only about 35% close spontaneously. If it's a large VSD, big hole, okay, then you have large flow to the right ventricle, large pulmonic flow. These patients can develop pulmonary hypertension because now there's greater flow because of the left to right shunt, more blood in the right ventricle, more blood going through the pulmonary vascular bed. These patients may develop pulmonary hypertension. They present with symptoms of heart failure, dyspnea, feeding difficulties in the newborn, poor growth. Babies in heart failure sweat profusely while feeding, and they go into heart failure. These patients have a lower murmur. It's a flowing, soft, holosystolic murmur, okay? And there may be a mid-diastolic rumble secondary to the excess blood flowing across the mitral valve. Left ventricle and left atrial hypertension are most common, and then if pulmonary hypertension develops, then they develop right ventricular hypertrophy as well. Complications of this is bacterial endocarditis, cardiac failure, and pulmonary hypertension. These patients need SVE prophylaxis. We'll talk about why later on, regardless of the size of the hole. Okay, small lesions generally do not require surgery unless it's limiting activity. Okay, large lesions, the symptoms of heart failure develop, particularly if there's no spontaneous closure. If you can't control the heart failure in large vessels, in large VSDs, then surgical correction is done. And again, it's usually a transcatheter closure. Then we have this guy. Okay, this is coarctation of the aorta. And this is the only congenital heart defect that you can diagnose without a stethoscope. Why? How do you diagnose coarctation of the aorta without a stethoscope? you palpate the femoral pulses. Okay? If you have narrowing up here, you're going to have decreased blood flow. You're going to have basically lower femoral pulses. And I will tell you that you should, on any new patient, check femoral pulses because people may have missed a coarctation of the aorta on patients. Now, only 5 to 7% of pediatric patients may have a coarctation of the aorta unless they have Turner syndrome. You know what Turner syndrome is, right? Single X chromosome. Web neck, shield chest, trident hairline. I showed you the one first lecture. 25% of all patients with Turner syndrome have a coarctation. So those patients should definitely be paid attention to. The most common location is distal to where the patent ductus was. Okay, so the patent ductus is there. Okay, and then they have the coarctation. Now, in infancy, okay, these patients may go into heart failure. Why do they go into heart failure? Well, because if there's a narrowing of the aorta and decreased blood flow to the distal part of the body, and the ductus stays open, then the right ventricle is supplying blood, okay, through the patent ductus to the descending aorta. So these patients are very funny because proximal to the coarctation is the oxygenated blood. Blood's coming back from the lungs to the left atrium, left ventricle, and blood is being pumped up to the head and upper extremities. So they're nice and pink up there, but when the blood from the right side of the heart is pumped to the lower extremities and the rest of the body, they're dusky. So they're pink on top and dusky below. This is maybe the presentation, okay, with a ductus open, okay? And because the right side of the heart is busy supplying blood to the lungs as well as to the lower part of the body, they may go into heart failure. They may develop pulmonary hypertension secondary to the load of the right ventricle having to pump blood to the rest of the body. Older children, once the ductus closes, okay, may be asymptomatic and it may just be diagnosed on routine physical examination. And the classic signs are decreased femoral pulses in the lower extremities, normal pulses in the upper extremities, okay, and the femoral pulses may be absent, and the blood pressure in the upper extremities may be higher, while the blood pressure in the lower extremities may be lower, which is the reverse of normal. Normal, the blood pressure in the lower extremities is higher than the blood pressure in the upper extremities. So if you have hypertension on normal blood pressure taking and absent femoral pulses, then you sort of have to think basically this may be a coarctation of the aorta. There's a short systolic ejection murmur, okay, along the left sternal border that radiates to the infrascapular area, similar to the murmur of aortic stenosis, okay. The EKG is usually normal in younger children. As they get older, they may develop left ventricular hypertrophy and they develop hypertension. Why do they develop hypertension? What organ that controls hypertension is not being perfused? It's the kidneys. Because you have a narrowing of the aorta and decreased blood flow to the lower extremities, the kidneys start complaining, I need more blood. So the kidney does its job to raise blood pressure. But if it's raising blood pressure by causing arterial constriction and increased cardiac output, what happens in the upper extremities and the head? Okay, now you have upper extremity hypertension in the upper extremities and the head. So as they get older, okay, they may develop heart failure, coronary artery disease, hypertensive encephalopathy, or intracranial hemorrhage because the kidneys will keep screaming for blood in the lower extremities. So the blood pressure goes up, and now you get CNS bleeds because in the upper extremities, you're hypertensive. Okay? This requires surgical correction. And the last of the congenital heart disease is aortic stenosis. This accounts for about 5% of all cardiac malformations. It's more common in males than females. Okay? And it may be the result of a bicuspid aortic valve, which is one of the most common congenital heart lesions overall. 2% of all adults have a bicuspid aortic valve. Okay? It also may be subvalvular or supravalvular and not just valvular stenosis. So the clinical manifestations tend to depend upon the degree of obstruction to the left ventricular outflow. Most children are asymptomatic. They grow fine and dandy, okay? But when they develop normal, if the stenosis is severe in neonates, the newborn then goes into heart failure, cardiomegaly, and pulmonary edema. With mild stenosis, okay, then everything, pulses, heart size, and apical pulses are all normal. A moderate stenosis, you may hear an early systolic ejection click at the apex that does not vary with respiration. The click of pulmonic stenosis varies with respiration, but the one with aortic stenosis does not. The typical murmur is a systolic ejection murmur, crescendo, decrescendo, paradoxical splitting of S2, okay? And the louder, the harsher, and the longer the murmur, it means the opening is smaller, it means the more severe the obstruction. And generally, severe obstruction, you feel a palpable thrill in the suprasternal notch. The EKG is normal in mild to moderate obstruction, and less ventricular obstruction. It's severe, okay? These are the patients that drop dead during marathons, okay? You know, you hear about somebody running a marathon at the end of the marathon that dropped dead. They probably had a bicuspid aortic valve or some sort of aortic obstruction, and during heavy exercise, they drop dead. Bacterial endocarditis is a possible, and it's severe obstruction heart failure. If it's valvular, it's easier to correct because all they do is pass a balloon through the aortic valve and then just rip it, and they make the patient, instead of aortic stenosis, aortic insufficiency, and the symptoms tend to abate. If it's subaortic or supravalvular, they require surgery, and as you get older, then they do valvular replacements. Okay, so that's see if I can do this. That's basically congenital heart disease. Now, how do I get the Word document up here? So now, before we talk about why congenital heart disease, we're going to talk about murmurs. How do we diagnose murmurs? Okay. Cardiology, it's the word, that one, yeah, that one. Okay.
Have you ever seen murmurs in your office? Like you diagnosed before?
What?
Like have you diagnosed murmurs in your office at the hospital can catch? Have you diagnosed murmurs in the office that the hospital can catch?
Yeah.
Oh.
I mean, just imagine trying to listen to a murmur on a baby whose heart rate's 140. Not easy. Okay, so I'm sure they told you how to classify heart murmurs from 1 to 6. Here's my classification. A grade 1 heart murmur is the hallucination of the cardiologist after he does the echo and he knows there's a beat. That's a grade 1 murmur. Okay? A grade 2 murmur is a murmur heard by somebody like me who's had experience in listening to murmurs, and usually it was never picked up by a student in my office, unless once I hear it, I go back and I say, listen, this is the murmur, and then you hear it. A grade 3 murmur you should all pick up. You should have no difficulty picking up in a grade 3 murmur. The grade 4 murmur is, oh my God, what the hell is that? Okay? I have never heard a grade 5, grade 6 murmur. The grade 5 murmur, they say, you hear it when you walk in the room without the stethoscope, okay? Or with the stethoscope off the chest, and a grade 6 murmur you hear from down the hallway. I have never heard a grade 5 or grade 6 murmur. I have no idea what they sound like. Okay? Grade 2 to 4 are no problem. So how do you listen to a murmur? Okay? I listen to a murmur different than you. Okay? When I listen to a heart, I just listen and this doesn't sound right, and then I pay attention and find out why it doesn't sound right. And that's after years of listening to hearts. Okay? When you're listening to the heart, the first thing you should do is only listen to the first heart sound. Block out everything else under the sun and just listen to the first heart sound. Then listen to the second heart sound. Now you know if there's a systolic or there's a diastolic murmur. Okay? And then listen to the space in between. Okay? So separate, don't just listen to the dup. You're not going to hear the murmur, particularly the higher the heart rate. Okay? So when I'm listening, I go, what the hell's going on with that? And then I pay attention and pick up the murmur. So I can pick up a grade 2 murmur because the heart doesn't really, through Gestalt doesn't sound normal to me. With you, if I hear a grade 2 murmur, I'll say to the student, only listen to the first heart sound, and then they'll hear the murmur. Okay? So separate each portion when you're listening to the murmur. That's number one. Okay? And then you know that basically the cardiologist told you timing, intensity, configuration, crescendo, decrescendo, pantasolic. But they teach you where it's located, patient quality. Okay. So that's number one. Okay. Okay. You all know about the various locations. Then we talk about distribution. Before we talk about distribution, okay, you want to know whether it's a systolic or diastolic murmur. Okay? So how do you check the timing? By coordinating the murmur with the pulse. So generally, you know whether it's just systolic and diastolic murmur. Okay? Innocent murmurs, one, are never diastolic. If you have a diastolic murmur, that is not an innocent murmur. Okay? Most murmurs are mid-systolic. Okay? And S1, S2 is never muffled or never split. If you have a split 6-second heart sound, that is not an innocent murmur. Okay? Innocent murmurs are never greater than grade 3. They're either grade 2 or grade 3. They're never loud enough that you have to worry about. Okay? So basically, those are the things basically about murmurs. Cardiology talked about crescendo, decrescendo. I'm not going over those, okay? So, what are the innocent murmurs that we talk about? Okay? Well, on the chart here, peripheral pulmonic stenosis. That's that one right there. Okay? Peripheral pulmonic stenosis. That one. Okay? That we see in the newborn. It's an innocent murmur. It's mid-systolic. It's grade 1 to 2. It's located over the upper sternal border with radiation into the axillary and lung fields. It's a crescendo decrescendo murmur. It's low medium pitch. This is seen in newborns with normal physical examinations, and we don't worry about this murmur. Okay? Then we have the venous hum. The venous hum is a continuous murmur, grade 1 to 3. It's located in the right infraclavicular space. Right infraclavicular space. Okay? Crescendo, decrescendo. They describe it as a musical or vibratory. It's never harsh. And generally they describe it as a whining or a roaring or a hum or radio static. And this is just a blood flow murmur. It is not a problem. Okay. And a venous hum is in young children here. Then comes the Stills murmur. The Stills murmur is the most common innocent murmur. It's an early systolic murmur, and like I told you, it's heard better lying down than standing up. Okay, grade 1 to 3. There's no palpable thrills, and it starts around age 2 and runs to about age 8. That's when you're going to hear it. Okay, basically, it's located over the apex of the left lower sternal border. You might think it's a VSD. It's not. Okay, crescendo, decrescendo, low to medium pitch, musical or vibratory quality, and we haven't a clue as to why it happens. It's just for, and this is the most common innocent murmur of younger children. This is what you're going to hear when you see a lot of these kids. It's a still murmur. The still murmur is a lot more common than any of the congenital heart disease. Then number 4, okay, in older kids is the pulmonary flow murmur. Again, this is the second most common innocent murmur, early to mid systolic, similar to a Stills murmur, grade 1 to 3, upper sternal border instead of lower sternal border. Okay, and basically crescendo, decrescendo, low pitch, rough, dissonant quality. So the 2 murmurs you are definitely going to hear if you're doing any sort of children is number 1 is Stills in the younger children, and number 2 the peripheral pulmonic stenosis murmur. I mean the pulmonary flow murmur. Okay, in older kids. And the last one is the supraclavicular carotid bruit, and this is basically blood flow in the neck. Okay, blood flow through the carotid artery, early systolic, grade 2 to 3. Again, low to medium quality, glowing in nature. So this is basically how you differentiate them. And basically the ones you are definitely going to see are Stills and pulmonic flow murmurs. And basically we talked about how you should listen to them. So what's the evidence of innocence? They're systolic. They are never diastolic. That's number 1. Number 2, they are always grade 3 or less. They are never greater than grade 3. Okay. Supraclavicular radiates to the lung. Generally, they're musical or vibratory. Innocent murmurs are never harsh, loud murmurs, and there's no splitting of S1 and S2, other than normal physiologic splitting. Those are the evidence of them being innocent. So if it's a diastolic murmur, you got problems. If it's a grade 4, you got problems. Okay? If it's a harsh murmur, you got problems. And if there's fixed splitting or splitting of S1 and S2, you have problems. And that's how you differentiate innocent murmurs from normal murmurs. Okay, so let's get rid of you. Okay, what did I do? Now I want to get back to the other slides. So that's how we talk about innocent murmurs and how we listen. So the next thing we're going to talk about, okay, we're going to go from congenital heart disease to acquired heart disease. And when we talk about acquired heart disease, we talk about acute rheumatic fever, infective endocarditis, infective myocarditis, and then the signs and symptoms of congenital heart failure in the newborn, which is different than in adults. So acute rheumatic fever. This is an acute inflammatory disease of connective tissue, and it involves the connective tissue, heart, blood vessels, joints, CNS, and subcutaneous tissue, which means essentially all the connective tissue in the body. Worldwide, rheumatic heart disease is the most common form of acquired heart disease in all age groups. 50% of acquired cardiovascular disease in basically underdeveloped countries. Here in the United States, in the early 1900s, the incidence of rheumatic heart disease was 1 to 200 per 100,000 population. And then it dropped to, in the early 1940s, to 50 per 100,000. Why? Why all of a sudden in the 40s did it drop? It wasn't because of antibiotics, because antibiotics didn't develop into the late 40s, okay? It was because less crowded conditions, less exposure, better hygiene, so it dropped. Currently, the incidence of acute rheumatic fever is 0.5 per 100,000 population. That means 1 every 200,000 people, okay? 5 per million. The chances of seeing rheumatic fever are poorer than winning the lottery, okay? People think rheumatic fever, oh my God, it's so common. It is not here in the United States. In 50 years, I have seen 2 cases of acute rheumatic fever. Some populations that think it's one of the most common childhood diseases because everybody who has a relative from the old country had rheumatic fever with heart disease. Well, there are 55 strains of strep, and only 5 of them cause rheumatic fever. 1, 3, 5, 6, and 18. Those are the only strains of group A beta hemolytic strep that cause rheumatic fever. And as of basically 2017, there are no circulating strains of group 1, 3, 5, 6, and 18 circulating in the United States. So that means, even if they were circulating, if somebody had a strep throat and you didn't treat them, the odds are 90 to 10 that they're going to get rheumatic fever because it's only 5 or 55. So basically, 1 out of 10 may, 10% may have rheumatic fever. That's statistics. We know that it's not circulating. So untreated strep infections, but believe it or not, is not going to give you rheumatic fever. Okay? If you have one of these strains and you get infected, okay, basically the signs of rheumatic fever show up 2 to 4 weeks after your infection. Peak age group for rheumatic fever is 5 to 15 years of age because these are the kids that are in school and spread it among each other. Now we know there's a genetic predisposition for developing rheumatic fever because it's more common in monozygotic twins than it is in dizygotic twins. I don't know why. And the next question is, why does a strep infection give you acute rheumatic fever? And nobody has a really good answer for that as far as I know. One theory was cytotoxicity, that the group A strep excretes a toxin that does the damage. Well, if it does, why does it take 2 to 4 weeks to show up? So another theory is an immunologic theory, and they think it's due to an M protein that or super antigens that the bacteria produces that gives you this immunogenic response to cause inflammation of subcutaneous tissue. Now, we make it very difficult for you to diagnose rheumatic fever. Why? Because I diagnose rheumatic fever in you. The treatment is miserable, and you'll never get life insurance and may not get health insurance because nobody wants to cover a patient who's already had rheumatic fever. So in order to make the diagnosis, we have what's called the Jones criteria. And there are major and minor Jones criteria. So the major criteria, Jones criteria, is carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. Those are the 5 major Jones criteria. So when we think about basically carditis, okay, carditis in rheumatic fever occurs in 50 to 60% of all patients who have rheumatic fever, okay? And it's diagnosed because the carditis is usually a valvulitis. It's diagnosed by a heart murmur. It's either an apical systolic murmur because the mitral valve has been damaged, you get mitral regurgitation, or a basal diastolic murmur of aortic regurgitation because of damage to the aortic valve. Okay. In addition to valvular disease, you can also get a pericarditis, a myocarditis, or a pancarditis in the severest form. That's the second most common presentation, or second most common of the Jones criteria. The most common of the Jones criteria is migratory polyarthritis. 75% of all patients with rheumatic fever are going to have a migratory polyarthritis, which generally involves knees, ankles, wrists, and elbows. If the arthritis involves the smaller joints of the hands and feet or the hips and spine, you do not have rheumatic fever. You may have juvenile rheumatoid arthritis, but you do not have rheumatic fever. So again, in rheumatic fever, it's basically knees, ankles, wrists, and elbows. These joints are red, hot, swollen, and exquisitely tender. I mean, the tenderness far exceeds what you're seeing on the patient. So if you're going to go to manipulate this joint, prepare to be smacked by the patient because they're in significant pain with these joints. And it's just the pain is out of proportion to what you're looking at. So those are the two major criteria. Then we have chorea. Okay, only 10 to 15% of patients with rheumatic fever have chorea. Okay, and it may be the only presenting sign of rheumatic fever. Now, one of my patients presented that way. They do not have the carditis, and they do not have the migratory polyarthritis. They just present with chorea. And how do you diagnose chorea? You tell the patient to stand with their arms out. Okay, most people can do that. If you have chorea, then you sort of get spooning of the arms, and they make abnormal movement of their arms. They cannot stand like that. That's choreiform movements, okay? Basically, with the arms extended, okay? Spooning and pronation of the hands when the arms are extended. Then there's the milkmaid's grasp. How many people have ever milked a cow? Okay. When you milk a cow, you pull down and release, you pull down and release. This is called the milkmaid's grip. When you shake the hands of somebody with rheumatic fever, they squeeze and release, squeeze and release, squeeze. It's involuntary. It's just like a choreiform. They're squeezing and letting go. That's called the milkmaid's grip. That's another sign of chorea. I'm sorry, the last one I can't demonstrate, okay? It's called the wormian tongue. When they stick out their tongue, they have fasciculations of the tongue that look like it's filled with a bag of worms. You've got all this kind of movement, involuntary movement of the tongue. Those are the three signs of chorea. And it may be the only sign of rheumatic fever. Less common are erythema marginatum. And when you look at the creature, it's a serpentiginous red that looks like it's crawling across the body. It generally occurs on the trunk. It never occurs on the face. Okay, it may occur on the extremities, and it's not very common. About less than 3% of patients who have a rheumatic fever may have erythema marginatum, and then there's subcutaneous nodules, okay? And the subcutaneous nodule is this thing right here. It's a nodule over the bony tendon, over a joint, okay? Those are subcutaneous nodules. If you have this is a severe case of rheumatic fever. It occurs in less than 1% of patients. It's the tendons over the extensive portion of surfaces. So these are the 5 major criteria. Then we have minor criteria. Arthralgia. What's the difference between arthralgia and arthritis? One's a major criteria, one's a minor criteria. What's the difference? Arthralgia is pain. No inflammation, no redness, no swelling, just pain. Arthritis, ITIS, means there's inflammation, so you have redness, tenderness, signs of inflammation. So the minor criteria are arthralgia, a fever greater than 39 degrees centigrade, elevated acute phase reactants. What's an acute phase reactant? Cedrate and CRP are your acute phase reactants. It's signs of inflammation. So that elevated acute phase reactants, prolonged PR interval on EKG, previous rheumatic disease or rheumatic heart disease. Those are the minor criteria. So to make the diagnosis of acute rheumatic fever, two majors. So you have two majors. If you have carditis, you have arthritis, okay, you probably have rheumatic fever. But what if you only have chorea? That's only one. And I said chorea may be the only one finding. Well, you have one major and two minors. So one of the major, two majors, or one major and two minors may have rheumatic fever. But if you have rheumatic fever, you better prove that they had a strep infection. Because if they didn't have a strep infection, then they don't have rheumatic fever. And we said rheumatic fever shows up 2 to 4 weeks after your initial exposure. Well, your throat culture or strep culture is going to be negative. It's 2 to 4 weeks after infection, unless you have a concurrent or continuous infection that hasn't been treated. Then your throat culture is going to be negative. So how else do we prove that you had a strep infection? An elevated ASO. An ASO stands for anti-streptolysis. That goes up early in infections, and depending how high they go up, they stay up for a prolonged period of time. Okay? Or you can do elevated anti-DNA speed titers, which are also indicative of a past strep infection. Okay? So, the strep test or throat culture only has a 10 to 20% response to patients with rheumatic fever, but an ASO is up around 80 to 85%, and an elevated anti-DNA speed, okay, maybe as high as 95 to 100% positive in patients with acute rheumatic fever. So how do we treat these patients? Number one, if you diagnose acute rheumatic fever, they go to bed, okay? Because you don't know yet whether they have carditis or not, and you don't want them ambulating if they have carditis. So they get put to bed, and then the first thing you do is you put them on antibiotic therapy, 10 days, to treat any strep infection that may be present in the body. Okay? So they get 10 days of oral penicillin or erythromycin. Now, what about anti-inflammatory treatment? If all they have is pain, arthralgia, and no other evidence of inflammation, okay, they go on Tylenol for the day. That's it. Okay, acetaminophen for the pain. If they have migratory polyarthritis or carditis, meaning you hear a murmur, a valvular murmur, all right, or they have migratory polyarthritis without evidence of cardiomegaly or congestive heart failure, they get salicylates as an anti-inflammatory. If there's cardiomegaly or congestive heart failure, then they go on steroids. So basically, the more severe the symptoms, the greater the anti-inflammatories that we use. Pain, acetaminophen. Mild inflammation with joints or valvular involvement, murmur, salicylates. Heart failure or cardiomegaly, steroids. That's how we do it. For chorea, and this may be the only manifestation of the rheumatic fever, if they have chorea, acetaminophen and other anti-inflammatories are not going to work. Okay? So basically, the treatment is sedation for the chorea. The drug of choice to start with is phenobarbital. And if that doesn't work, then haloperidol or cloprovazine. You have the pharmacology, right? What's the side effect of haloperidol? Anybody remember? No, you took the test and forgot it all. What? You had the test next week? Oh, okay. Tardive dyskinesia is the side effect of haloperidol. What's tardive dyskinesia? Huh? What's tardive dyskinesia? Involuntary or purposeless movements. That's tardive dyskinesia. So what do you want to do? Get rid of their purposeless career form movements by giving them a drug that's going to give them purposeless movements. So I wouldn't use haloperidol, phenobarbital. I would use haloperidol. It wouldn't be my first line drug for the career form movements. Then we have to do prophylaxis after the initial treatment of rheumatic fever so it doesn't come back. Okay? Maybe it has to give them severe cardiomegaly and congestive heart failure, but if they get another strep infection with the bugs that may cause it, it may do further damage. So we do prophylaxis. Prophylaxis is 1.2 million units of LA bicillin given monthly. Anybody ever give LA bicillin? You know what it looks like?
The white thing.
It looks like molasses. And it has to be given with a 16 gauge needle because it's so thick it doesn't go through normal 21 gauge needles. And how long do they have to get the LA bicillin? If you have no carditis, all you had was migratory polyarthritis, you give them LA bicillin for 5 years or to the age of 21, whichever is longer. Now, we said the peak age is 5 to 15 years of age for strep infections. So if you have a 9-year-old kid who has rheumatic fever, he is going on monthly injections with LA bicillin for 12 years. And that's assuming he has no carditis. If he has carditis, they go on LA bicillin for 10 years or well into adulthood, which means into their 20s and 30s. And if they have residual carditis, they go on it at least till the age of 40. Now you know why we don't want to make an easy diagnosis, giving people LA bicillin every single month for 30 to 40 years. Okay? So again, this is the ones that we want to pay attention to. And we don't give them oral antibiotics, even though my notes say you can give oral antibiotics, because most people, they take their birth controls regularly. They don't take their cardiac medication regularly. You expect them to take oral medication every single day for 10 to 20 years? Not going to happen. So that's why they come into LA Marcel. Okay. So basically, that's acute rheumatic fever. Now, you don't have to write this down. Okay. Nobody does differential diagnosis anymore. Because basically, if you have a symptom, you don't know what it is, you Google it, it'll give you a differential diagnosis. Okay, in the dark ages, we had to learn differential diagnosis. So what's the differential diagnosis of a person with arthritis? Well, yeah, it could be acute rheumatic fever, but it also could be rheumatoid arthritis, lupus, septic arthritis, Lyme disease, serum sickness, drug reaction. Now, most of these are a lot more common than acute rheumatic fever. And if we're talking about endocarditis, yeah, rheumatic fever can damage your valves, but so can a viral myocarditis and infective endocarditis, which we'll talk about. A bicuspid aortic valve can give you a similar murmur, or a mitral valve prolapse, okay, can give you the same type of murmur as rheumatic fever. Functional murmurs, congenital anomalies, sickle cell disease, okay, all can give you heart murmurs. Chorea. Besides chorea of acute rheumatic fever, you can have chorea secondary to Huntington's chorea, Wilson's disease, not Wilson's diseases, abnormality of copper metabolism. They get the defects of the iris of their eyes. Okay, lupus, drug reactions, sleep disorders, hyperkinesis, conversion reaction can all give you abnormal movements. Okay, we'll come back to you in a minute. Okay. So now we're going to talk about infective endocarditis. And we're talking about this because this is the one that I said were potential complications of all forms of congenital heart disease, except one. Okay, so And we draw the heart with an ASD. We draw a heart with DSD. We draw a heart with coarctation aorta. And we draw a heart with pain vessels. Those are the ones that potentially can give you bacterial endocarditis, except one, which is the one that won't give you risk for endocarditis. I told you. It's the atrial septum. This one will not give you um, risk for endocarditis. So, with a VSD, every time the heart contracts, get blood flow through the VSD to the opposite endocardium. Well, the Grand Canyon was caused by the flow of the Colorado River. So, with every heartbeat, if you're beating against here, you're going to damage the endocardium. So, the body gets smart. It sets up a sterile clot to protect the endocardium from the blood flow so you don't get damage to the endocardial wall. But anytime you get a bacteremia, how often do you get a bacteremia? Every time you brush your teeth, you get a transient bacteremia. So if you get a bacteremia, okay, and you get the little bacteria coming into your body, okay, and then it comes down here, okay, and it comes through here, okay, and it's being chased by white cells and, you know, your immunologic response, okay, where does it go? Oh, there's a nice place to set up living. We can live right here, and white cells won't be able to get at us. So they take up residence in this sterile clot, which is no longer sterile. And then the bacteria do what they're supposed to do, okay? They become fruitful and multiply, and soon there's no room for them. So now they leave the clot, and then you get repeated episodes of bacteremias, because all the bacteria are being released from the sterile clot. So suddenly you get bacteremias, spiking fevers, feeling lousy. These are the signs and symptoms of endocarditis. All right? So anywhere where there's a heart defect, where there's high pressure flow that can do damage, you're at risk for endocarditis. So you have a PDA, okay, where you get blood flow from the aorta, pulmonary artery. That's high pressure flow. You get a high pressure flow through the coarctation to the wall of the aorta. That's high pressure flow, okay? Anywhere where there's high pressure flow that can damage the endocardium. These are the ones who need prophylaxis to prevent against a bacteremia that can infect the sterile clot that's been established to protect the endocardium that's being damaged by high flow. The flow between the atriums is essentially equal pressure. We said the murmur is not the flow through here. The murmur is up through the pulmonic valve, the pulmonary artery, through the increased flow. So an ASD is the only one where you don't need bacterial prophylaxis. And I said to you, every time you brush your teeth, you get a bacteremia. So that's when dentists decided anytime they're going to do dental work on you, okay, if you have you're at risk for a bacterial endocarditis, okay, we should give you prophylaxis to prevent this bacteremia from becoming a problem. Do you know when the article or the association of bacteremia and heart disease and dental work was published? 1909, before antibiotics. Dentists were figuring out every time they did dental work on people, they wound up with heart disease. That's when it was first published. So that when I was in medical school in residency, anytime you had a heart murmur, you went to the dentist, okay, and you were put on antibiotics. and you will put on antibiotics for a day before and a week after, prevent you from getting, a bacteremia and subacute endocarditis. That was a lot of people on antibiotics. If you had an innocent murmur, there was nothing wrong with your heart. Why were we putting you on antibiotics? Because the dentists were all afraid that basically, if you developed a bacteremia, it might damage your heart, so you were put on it. So I guess 1980 something. Okay, when was the start of the group? No, it was in 2011. Okay, the cardiologists got together and said everybody does not need antibiotic therapy if they're having dental work. Okay, it's only a select population. If you just have an innocent murmur, you do not need prophylaxis. So who's getting prophylaxis? Okay, if you have uncorrected, okay, congenital heart disease. If you have congenital heart disease, which was repaired, which you have some residual problems with, you get prophylaxis. If you have an artificial heart valve, you get prophylaxis, or if you have a previous history of endocarditis. Everybody else does not need it, meaning if you have mitral prolapse, you don't need it. If you have an innocent murmur, you don't need it. Okay? So, when we're talking about infective endocarditis, basically we're referring to entities either acute or subacute. It can be caused by bacteria or viruses. Okay? And basically, the organisms are changing because, we have different patient populations now. Okay? So, who are the patients where there's an issue for maybe delayed treatment? There are special risk groups that are at greater risk for developing subacute bacterial endocarditis. IV drug users. If you're an IV drug user, you're not using sterile equipment. You're injecting bacteria or virus into your blood vessels. If you have any at-risk situation going in with your heart, you are going to be put at risk for endocarditis. Okay? Status post-cardiac surgery, well, we talked about that. Valvular replacements, repair of congenital heart disease. Okay? You're at risk. Okay? People on immunosuppressive medications, or people who have chronic indwelling catheters, like people who are getting chemotherapy. Okay? They have shunts put in so that they can get their IV medication through the shunts, okay, through the indwelling catheter. Well, if it's being done through an indwelling catheter, there's also a point of entry for the bacterium to get in. They're at greater risk also. Okay, so these are the patients at greater risk that you have to be aware of that may need prophylaxis. The leading cause of endocarditis, okay, is strep viridans or Staph aureus. Yeah, group D enterococci, Pseudomonas, Serratia can also do it, okay? And basically, 6% of all blood cultures will be negative for any organisms. So again, we diagnose endocarditis with blood cultures, and yet 6% of patients, their blood cultures may be negative. Staph aureus, okay, we see in patients with no underlying heart disease. Sometimes patients with no underlying heart disease can develop an endocarditis if they have a significant staph infection. Strep viridans, that's the one that follows dental procedures. Okay, enterococci may follow bowel surgery. So you have an at-risk patient who's having bowel surgery, you have to protect them against developing an endocarditis. Pseudomonas or Serratia IV drug abusers, and very often fungi after post-op cardiac surgery. So it's a complication of congenital rheumatic heart disease. But in children, it may occur in children without any abnormalities of the heart. Okay, and just damage is done by normal streaming of blood. So, clinical manifestations, they may be mild, prolonged fever and weight loss for months, or they may be sudden and acute, high intermittent fever, prostration, usually somewhere between the two. And what are generalized symptoms? Fever, chills, chest, abdominal pain, arthralgia, myalgia, dyspnea, weight loss, malaise, night sweats. Night sweats are never good. And these patients may present with strokes, seizures, or headaches. Physical signs: fever, tachycardia, and heart failure. And one of the hallmarks are embolic phenomena. They talked about splinter hemorrhages, didn't they? Right? They mentioned splinter hemorrhages. Okay, how do you see where is splinter hemorrhages usually? In the nail beds. Okay, they may have ocular lesions, they may have CNS lesions, but evidence of embolic phenomena are usually splinter hemorrhages. Well, if you want to see splinter hemorrhages, the best way to see them is with the microscope that you carry around in your medical bag. Now you look at me, I have 3 heads. I don't carry a microscope around in my medical bag. Yes, you do. It's called the ophthalmoscope. The ophthalmoscope has magnifying lenses in there. So if you think a patient has splinter hemorrhages and you're looking and you don't see anything, put a drop of oil on the nail bed, take your ophthalmoscope and focus down through the oil on the nail bed, and you will see the splinter hemorrhages. And that's probably the way you'll see them. Although I don't know how many cases of bacterial endocarditis you will see. Okay, splenomegaly, arthritis, arrhythmias can occur with endocarditis as well. So how do we diagnose endocarditis? It's usually by blood culture. And when I was a resident, they used to say, the best time to take a blood culture is an hour before they spike a fever, because you get the bacteremia, then your body responds and spikes the fever. When you want to get the blood cultures, the best ones to take it right before the fever, because that's when the bacteremia is the highest. That was nonsense. Okay, if you take basically 3 to 5 samples with aseptic technique, you will get a positive blood culture in about 90% of the cases. And that's how we diagnose acute endocarditis, okay, is with a positive blood culture. Because you really want a positive blood culture, because the treatment for this takes a long time. It's IV antibiotic therapy for 4 to 6 weeks. So how do we prevent it? By prophylaxis, that's what we talked about, okay? So once you diagnose which patients are at risk for developing an endocarditis, okay, what's the prophylaxis? The prophylaxis, okay, is 50 milligrams per kilo of ampicillin up to 2 grams 1 hour before procedure. That's it. It's not for the day of the procedure and a week after. It's 1 dose of 50 milligrams per kilo, okay, an hour before the procedure. That's all you have to do. If they are allergic to amoxicillin, you can use clindamycin or oral azithromycin. That's endocarditis. The diagnosis that you ever hope you see is infective myocarditis. Endocarditis is an inflammation of the lining of the heart. Myocarditis is an infection of the cardiac muscle. And that's a total disaster. Fortunately, it's very rare. I've only seen 2 cases in all my years, and they both occur in the same summer. One was in Vanessa. Vanessa was a patient who was born with no suck, no gag, and no swallow reflex. So she had to be tube fed. She was at risk for aspiration. She needed nasal suctioning. And the parents wanted to take the kid home, despite they had 3 kids at home. So my friends in the NICU said, "Oh, we know somebody who will work with you." And they gave her my name and address. So they called me and we met and I made a pronouncement. And this is where you learn never ever to make pronouncements. I said to them, "Listen, I'm willing to work with you. I know they taught you how to have 2 feet and how to do suction. Very often these kids die within the first year of life from aspiration, choking, and what have you. But I'm willing to do whatever it does." Okay. They stayed up at 4 hour sessions, suctioning and tube feeding this kid. And the kid subsequently developed a gag reflex, a swallow reflex. She can eat, by herself. She was intellectually impaired. She went to early intervention. She developed speech. She would talk to everybody but me. Okay. And I was invited to her Sweet 16. Okay. That's what happens when you make a pronouncement that she's going to die at a year of age. Proves you totally wrong. Okay. Then they moved away to New Jersey, and we get a phone call. She's 18 years old. Okay. The doctors here are treating her for pneumonia. She's not getting better. Can we come back and see you? Yes, you can come back and see. Okay. She comes back to the office, and she doesn't have pneumonia. She's in frank heart failure. She has a gallop rhythm. She's hypotensive, and she's got rails from the pulmonary edema. So I'm making now she's an adult. She's 18, 19 years old. She can't go to the pediatric ward. I'm making reservations for her to be admitted to the adult ward. She's sitting in the waiting room screaming, "I don't want to go to the hospital." And they get to the hospital, goes to the CCU. They pass a Swan-Ganz catheter. Okay, cardiac respiratory arrest, and dies. And on autopsy, okay, she had acute myocarditis. Okay, and she was positive for Coxsackie B virus, which is the most common cause of acute myocarditis. So when we poo-poo hand, foot, mouth disease, and we say it's swimming pool disease, and we say everybody gets it when we open up. One day, that swimming pool disease is going to show up in your office looking like this. That was in July. In June, my partner gets a phone call from a mother of a kid who was the sister of former Toro student. My kid is pale, and weak and lethargic. She's white as a ghost, but she has a period, so I think that's what it's due to. Why they blame everything on the menses, I have no idea. Okay? My partner says, "Yeah, come into the office." She gets to the office. She's markedly hypotensive and just about in shock. Calls the ambulance. She winds up at Mount Sinai Hospital. Okay, and she dies as well. Okay, because the only treatment for acute myocarditis, okay, is supportive care and cardiac transplantation. So generally, Coxsackie B is the most serious of all the bugs that cause it. Okay, the true incidence we really don't know because patient may get it, may have a slow progression of the disease, certainly winds up in heart failure, and nobody knows basically what triggered it. Okay, and again, they come in with fever, severe heart failure, respiratory distress, cyanosis, distant heart sound, weak pulse, tachycardia. I mean, that's how all these kids present. And basically, 50% of these patients will die within 2 years without treatment. Yeah.
For
come in and like you report therapy, how long is it? Like how long could you wait for a cardiac transplant before they die?
Well, they die within 2 years after that,
Of when the session start,
when you make the
of
diagnosis.
when you make them.
Yes.
So why did those patients like pretty much die right away? The ones
They had fulminant disease. I mean, they came in shock, severe disease, okay? And any supportive medications did not work. That was the problem. We couldn't support them long enough to get the heart transplant. That's what the issue was. Okay? So that's effective endocarditis. And hopefully I'm never going to see another unless it comes in within the next 6 weeks. Okay? So this I never want to see. Now, heart failure in infants. What are the signs of heart failure in adults? What? Where? Pretibial edema, tachycardia, okay? Tachycardia, tachypnea, hepatomegaly. Well, you don't see pretibial edema here. Babies get poor feeding, tachypnea, tachycardia, and hepatomegaly. Why the hell don't they get pretibial edema? Adults get it. Why don't kids get it? Why don't infants get pretibial edema as a sign of heart failure? Not because they're small.
They're not standing.
What?
They're not standing.
They're not standing. They spend their time on their backs. That's why they don't get pretibial edema. Okay, so that's the end of cardiology. Now, I'm just going to start pulmonary, and I'll come back and start it. Talk about it when I come back. I'm just going to talk about when I start the pulmonary lecture. You've all had physiology, right? You've all had pulmonary. Yeah, we'll see how much pulmonary they teach you. Okay. How do we breathe? Well, before that, okay. Briefly, embryology. I mention embryology only because it's 3 things for the respiratory sector. Okay. One is surfactant production. I mean, it's sort of important. So surfactant production begins, okay, at about 22 to 24 weeks gestation, and then it's enough to permit survival somewhere between 27 and 28 weeks, right? 30 to 34 weeks to feel the development is complete. But the most important thing about the embryologic development of the respiratory system is it's not complete until 8 years of age. Which means, well, why? Because as you get bigger, you need a bigger pulmonary capacity, so you need increased branching and enlarging of the lungs, which means anything of the pulmonary tract, respiratory tract, that influences pulmonary status can have long-term effects well into adulthood because it can affect growth on the lung. I assume you know anatomy, right? So if I say what the glottis is, you know what I mean by the glottis and the subglottic region and the supraglottic. Thank you. Okay. And you all know the muscles of respiration, right? Besides the diaphragm. Okay. What are the other muscles of respiration? Intercostals. Go ahead. And what are the accessory muscles of respiration? What? Rhomboid scalene? Okay. So now we know anatomy. Here is the question: how do we breathe? How do we breathe? What happens? What? Yeah, how does normal breathing happen? What? It's automatic. What happens? How do you get air into your lungs? What happens to the diaphragm? Okay, the diaphragm moves down. What happens when the diaphragm moves down? It creates negative pressure. I'm asking this for a reason, you know that, okay? And air goes down the path of least resistance because nature abhors a vacuum. So air goes into the nose, down the airway, into the lungs to equalize the negative pressure. And then when we breathe out, the diaphragm moves up, you create positive pressure, the air leaves. Okay. What if we have obstruction to the normal flow of air? okay? Acute epiglottitis, okay? The croup, okay? What happens if the air can't get down the normal pathway? What do you see? What are the signs of respiratory distress besides tachypnea? What? Use of accessory muscles. Yeah, what else?
Tripods.
They're called retractions. Why do retractions happen? Intercostal retractions are the sign of respiratory distress, right? In infants and small children, you can get suprasternal retractions, you can get substernal retractions, you can get in very small kids, because the costo-sternal junctions are not very rigid, you can get complete sternal retractions. Why in the world does that happen? Because nature absorbs a vacuum. So if it can't go down the normal airway, it tries to get into the thoracic cavity any way it can. So it doesn't make it, but it tries to get in between the ribs. It tries to get into the suprasternal notch. It's trying to equilibrate the pressure, and it can't get into the chest cavity. That's why we have retractions. That's why that's a sign of respiratory distress. Okay? And when you're having respiratory distress, okay, why are you using accessory muscles of respiration? What is the body trying to do when you're having difficulty getting air into the lungs? What is the body trying to do?
Create that negative pressure.
What?
To create the negative pressure.
Create increased negative pressure. How? What do they pull up on? Your accessory muscles of respiration. They pull up on the rib cage, pulling up, attempting to increase the AP diameter of the chest to get air into the lungs. That's why they do that. Okay? So that's why use of accessory muscles of respiration are what we use. Okay? So if I have somebody in respiratory distress and they need to be intubated, what size tube do I pick? Is the anus diameter of every one of your airways the same? No. So what's the approximate size of the inner diameter of the airway? It's about the size of your fifth finger. That's the internal diameter of your airway. That's the size of the tube they're going to shove down your airway to get you to breathe. Okay, well, I have a fat finger, so I have a fairly large airway. What about a baby? Okay, yeah, okay. So who gets into distress more? Big people or babies when they have compromise of their airway? Babies. And what's the formula? Oh boy, now we're going. The formula for resistance is resistance equals the radius to the fourth power. It's 1/3. That's the formula. Okay? So if I decrease your radius by 50%, how much am I increasing the resistance? Well, it's 2 to the fourth power. What's 2 to the fourth power? Oh my God, we don't have to do that either. 2 times 2 is 4, times 2 is 8, times 2 is 16. So a 50% decrease in the diameter of the radius of your airway increases resistance 16 times. And that's why kids get into greater respiratory distress than adults do, because it doesn't take much to decrease the airway in a small child by 50%. Okay? Now, I know people who teach you pulmonary disease love to talk about restriction and obstructive airway disease, right? They busted your chops with that. Okay? It's in my notes. I will not ask you about it. Okay, not at all. When we talk about respiratory problems in children, okay, we talk about upper airway issues and lower airway issues. So what's part of your upper respiratory tract? But anatomically, what's part of, when I say upper airway disease, what makes up the upper airway in your body? What? Oropharynx, nasopharynx. What? Everything above the cords. Okay? Sinuses, ears. Okay? Those are all part of your upper respiratory system. Lower respiratory system is everything below the vocal cords. Okay? So, trachea is also part of your upper airway. It's above the cords. Well, the larynx is the trachea is lower cords. Okay? So, when we talk about the common cold, it is not a URI. Oh, no. These are people wanting money. These are people, these are, when we talk about the common cold, an upper respiratory infection means nasopharynx, oropharynx, ears, or sinuses. But the common cold is, the real name for the common cold is rhinosinusitis. That's the real name for a common cold, not a URI. Because otitis is a URI. The tonsillitis, okay, is a URI. Okay, so the common name for the common cold is a rhinosinusitis. And they don't teach a medical history at all. But there was a guy by the name of William Osler, who was the founder of modern medicine. And he, in his writings, said that the only way to treat the common cold is with the pen, because there is no other treatment for the common cold. Okay? And when we talk about the common cold, it's defined as an illness, and you all know what it is. It's a runny nose with nasal obstruction without any systemic symptoms, maybe low-grade fever, but generally no high fever, no muscle aches. It's just a drippy, runny nose and nasal congestion. And there are 200 viruses that cause the common cold, and once you have them all, you don't get sick again. Okay? I haven't had a cold and I don't know how long. Okay? You will all get sick when you take your pediatric rotation. Okay? Because you're going to do a throat culture on the kid, and you say, open up, the kid is going to go right in your face, and then you're going to catch whatever he has. So you will all get sick. You'll all get sick for your pediatric rotation. It's routine. Okay? So the rhinovirus is responsible for 30 to 50% of the cases. Next comes coronavirus, and then parainfluenza, influenza, RSV, adenovirus, enterovirus, maybe mycoplasma can all give you symptoms of the common cold. The common cold is the most infectious disease, okay, of childhood. They occur all year round, more common in the winter months. Number one, rhinovirus is August to October and April to May. Parainfluenza is the late fall. Then we got RSV and influenza December to April. Now, younger children have 6 to 7 colds a year. Remember the lecture I gave you that you tell parents when they turn a year of age, I tell them they can be sick once a month. Well, if they're in daycare, they're going to have a cold every single month. Okay, so that's 12 their first year. Okay, and basically the first 2 years, let's say they get 12 a year. That's 24. Okay, then they can turn 3. Okay, I mean they turn 2. Now the third year of life, it drops to 3 a year. So if there are 200 common colds, okay, after the first 2 years of life, you have 176 to go. And if you average 3 a year, okay, by the time you're 50 or 60, you don't get common colds anymore because you've had them all. Okay, so this is what you have to look forward to. Okay, the incubation period of a common cold is 1 to 3 days. You all know the symptoms. Okay, scratchy throat, stuffy nose, runny nose. Okay, a cough maybe. About 30% will develop a cough. The symptoms usually last a week, and we usually say if I treat the common cold, it takes a week to get better. If I ignore it, it takes 7 days. Okay, because that's how long they last. 10% may go on to last a week or two. Okay, the change in color and consistency of your nasal secretions mean nothing. Mucus goes from white to yellow to green the longer it lays around. So you don't need antibiotics for a green nasal discharge, despite what other people say. Okay, let's talk about the treatment for the common cold. Okay, there are some antivirals, but there are none specific for the common cold. First generation antihistamines, like Benadryl. Benadryl may make you feel better with the common cold, but it's not because of the antihistamines. First generation antihistamines have anticholinergics. So the anticholinergics dry you up. That's why you feel better with Benadryl and don't feel better with the current antihistamines, because the current antihistamines have no cholinergic in them. Okay? Now, ineffective treatments. Vitamin C doesn't work. Guanefacin doesn't work. Okay, echinacea. Some people swear up and down that echinacea makes them better. The NIH did a study with 700 patients from childhood to 80, and they gave them either echinacea as directed or a placebo. And they measured how long it took for their symptoms to get better. 12 hours on echinacea. So the echinacea fanatics said they didn't use high enough doses. Okay, echinacea doesn't work. Maybe psychologically it works, but it doesn't. Okay, if you have a cough, what's the best cough medicine in the world? Honey. Honey is the best cough medicine in the world. Why? Because it coats the throat. It has an antibacterial effect. You know, honey never goes bad, ever. And in the bad old days, they used to pack wounds with honey to prevent infections, because honey has an antibiotic or antibacterial effect. So that may work for the cough. Okay. Zinc. Have you heard of zinc for the common cold? In order for zinc to work for the common cold, you need 40 milligrams or higher a dose. And you can't get 40 milligrams because the stuff tastes terrible, and at 40 milligrams gives you miserable side effects. And the people who make treatments for the common cold combine zinc and vitamin C. You've seen those in the market, right? Vitamin C and zinc. Vitamin C blunts the effect of zinc. So the only people who are getting benefit from these cold tablets with zinc and vitamin C is the company making them, not you. Okay, so that doesn't work either. Okay, the only thing that has been shown to be effective, okay, is salt water nose drops, saline nose drops in kids. Study came out in 2004, giving kids saline nose drops. The two things that happened is it shortened their symptoms by 2 days, which is certainly better than echinacea, and it decreased the risk of spread to other members of the family. So saline nose drops may work better, okay, than echinacea or anything else. Complications of the common cold: acute otitis media, sinusitis. If you're an asthmatic, your asthma symptoms may get worse. Okay, and the biggest one is the inappropriate use, basically, of antibiotics may be an issue when it comes to. That's probably the biggest side effect of the common cold is using antibiotics